Varsha.
Good afternoon, sir.
Is there two? Yeah, good afternoon. If anyone has two devices together, no, then the echo will come.
Hello everyone.
Varsha, are we live?
Can you see me?
Not you. We can't see you. I mean,
I'll
we can.
rejoin. I don't know. I'll rejoin.
Okay. So as soon as we go live, just let me know.
Sure, sir. So we are live.
Good afternoon, everyone. Greetings from Dr. Rasik Shah, Senior Pediatric Surgeon at SRCC Children's Hospital managed by Narayana Health. This is testing time with COVID lockdown in Mumbai, and I think many of you are working and a lot of COVID patients all around. Today, our theme is on fetal medicine. As you know, that at SRCC Children's Hospital, we have started with fetal medicine department. Now, when we say fetal medicine, we give comprehensive care, which starts antenatally, starting from the anomaly scan and other things, which we'll be discussing today. Then we can even deliver the patients, particularly high-risk fetuses, we can deliver in-house. So the earlier what was happening that these high-risk fetuses were being delivered somewhere else and then transported to SRCC Children's Hospital. Now the transport in warm is the best, and hence we have started this facility for the fetus or newborn so that they can be delivered at SRCC Children's Hospital, and then further care in the newborn period, whether it is just medical care in NICU or surgical care can be taken care of. As all of you know, we have all subspecialties to take care of the newborn, whether it is pediatric general surgery, whether it is cardiac surgery, neurosurgery, whatever we need, we have all the people in under one roof. And that is the strength of SRCC, and now it is extended further to take care of the deliveries as well as the high-risk fetuses in antenatal period. Now, to discuss about this new thing, what is happening in the fetal medicine, we have galaxy of speakers today, and all that will be introduced by Dr. Rujul Gujarathi or Rujul Javeri. She is our associate consultant in fetal medicine department, and I will request Rujul to take over from here. She will introduce the speaker program, and after each speaker talk is over, even the question answer, if you have any, you can write it in the chat box, and she will ask and then we will continue with this program. Our next program, which will be after 3 will be the theme of the transplant, which include liver transplant, renal transplant, and bone marrow transplant as of now. So over to Dr. Rujul Gujarathi. Rujul, please go ahead.
When I am Dr. Rujul Chavedi, this is one of the most important period for a pregnant couple because it starts from beginning of the pregnancy to location of the pregnancy. And as we go ahead to the first trimester scan where we are discussing and detecting all the chromosome aneuploidies as well as any other first trimester.
Your voice is cracking, Rujul. I think where you are sitting, signals are not very good. I can't hear you. Anyone else can hear? No.
Oh, we can't hear you, Dr. Rujul.
So what we will do, I think our signals are not coming. And our first speaker is Dr. Shilpa Agrawal. And she is going to tell us about high-risk pregnancies and biochemical markers. And she is the senior specialist taking care of high-risk fetuses. She has been trained at Hyderabad in one of the high-risk pregnancy centers. She has done even sonography course and genetic specialty. All this was supposed to be told by Rujul, but somehow the signals are not good. So I will tell Dr. Shilpa Agrawal to take over and start with her talk.
Yeah, thank you so much.
Short introduction along with that. Please go.
Thank you very much for that introduction. Good afternoon, everyone. It is real a privilege for all of us to share our ideas with you all. We know that you are a very important link between our patients, and you actually have a very important role to play. So we thought it should be transmitted to you what all we are doing at SRCC. So I'll just share my screen. My screen is visible?
Yes, please go ahead.
Yeah, so my topic today is about high-risk fetus and screening in pregnancy. So now this is a quote which I always love and I always put it before my presentation. The history of mankind for the 9 months preceding birth are far more interesting. So the 9 months which are there for the fetus, they are the most interesting part of our life, and obviously everybody agrees to that. Now, what is a high-risk pregnancy? So I'll start my presentation with the simple definition of what is high-risk pregnancy. So high-risk pregnancy basically involves any risk factor to the mother or to the fetus. So it can be either a problem for the mother or for the fetus. So today we will focus on what is high-risk fetus. So high-risk fetus, basically any fetal problems which are diagnosed in the antenatal period, basically categorize them into high-risk fetus. To name the few examples, and the commonest ones are fetal growth restriction, we come across day in and day out, and any preterm delivery, screen positive, any genetic problem, whether in the previous baby or in the family, any previous baby with any problem, twins and multiple order pregnancy, any malformations detected in the ultrasound, any Rh negative pregnancy, fetal infections, for example, any rubella or any any other fetal infection, and many more to add to the list. So I've just enumerated few common problems which we come across during our practice. Now, let us see what happens. See, when a patient comes to us and when we diagnose any fetal problem, So the patient now with the fetal problem will go to a fetal medicine specialist. If suppose then, for example, if there is a cardiac problem in the fetus, in the baby, in the antenatal ultrasound, then we will have a cardiologist opinion. If it's a correctable, surgically correctable, then we will have a pediatric cardiac surgeon. We will also involve a geneticist, so there will be a genetic counseling. So patient will run from one person to another, from pillar to post, for all these references. So what will happen? The consequences, the couple is totally confused, they are frustrated. Sometimes because of all this, the pregnancy goes beyond 20 weeks. They will terminate. Now that they are frustrated, they will think that, okay, fine, we don't want to do any investigation, we just want termination. They might terminate it after 20 weeks with illegal manners, which is again will jeopardize the health of the mother, and we will lose important information. So in case if amniocentesis was needed, it was not done, we will lose an important information. So this is what happens when we make patient go from one hospital to another, from one doctor to another. So basically, what are we doing at SRCC? So we are giving all this care under one roof. And I think that is the most important thing, because we want our patient to have all the references, all the opinions under one roof. So the patient comes to the hospital, will be seen by a fetal medicine specialist, will be seen by an obstetrician. If at all needed, we can refer them to any subspecialty, and the thing will be done for that patient. Obviously, the management dilemmas will be there, but at least it will be all under one roof. And that is, I think, very, very important, because we know that pregnancy is such a happy moment for the family. And when with this happy moment, we say that something wrong with the baby or the mother, the happiness is totally replaced by frustration and depression. So we need to take care of them. And I feel one-stop clinic is an answer to such problems. Now, let us see about screening. So screening, if we see, it is a simple thing. You check the blood of the mother, you check the baby by sonography, or you do both, and the answer is done. Or you just make assumptions that, without doing anything about the pregnancy is good. But that is not the case. So screening is simple, is what we understand, because we know that it only involves blood and sonography, but it is not that simple. So if we see the graph, we can see that it has come from the place where we only had maternal age, then we evolved over a period of time, and now we are at a place where we are doing non-invasive tests by NIPT. So we have come down a ladder where we were doing only maternal age association and Down syndrome, but now we are in a very better position. But again, with all this have come confusion and dilemmas for the family. So what is a good screening test? A good screening test will have a high detection rate. So the higher the detection rate, better is the test. And what is a false positive rate? So lower the false positive rate, better is the test. So we should have a good detection rate, and we should have a low false positive rate for any good screening test. Now, this is just a chart which shows how we are screening in pregnancy. So basically, pregnancy screening will involve screening for diabetes, screening for preeclampsia, screening for any genetic problems, screening for any malformations in the previous pregnancy. So screening basically involves everything, but today we will concentrate on the screening for aneuploidies or chromosomal problems. So we know that the trimester, which is first trimester and second trimester, so the important test is in first trimester. See, usually patient and mainly mother-in-law, they feel that patient should not go to the hospital till 3 months of pregnancy. But I think we should just tell them that this is not the case. We have to report so that the next steps which are important can be taken at 12 weeks of gestation. So first trimester screening and second trimester screening. First trimester screening is better than second trimester screening. First trimester screening will involve two things. One is the blood test and one is ultrasound. Then it is called as a combined first trimester screen. So we involve the blood test and the scan. And this, the cell-free DNA is the NIPT, which we do only if required. It is not a universal screening method as of now in India. And the ones in oval shaped are the invasive tests. So in first trimester, we have chorionic villous sampling, usually after 10 weeks. And in second trimester, we have amniocentesis, which is after 15 weeks. So, and in second trimester, the blood test which we do is quadruple screening. So, which is again less sensitive and specific as compared to your first trimester. So, our main agenda should be first trimester screening. Now, remember, this gestational week is very, very important, 11 to 13 plus 6. And CRL is the crown rump length of the fetus on ultrasound, though it is not important for you all, but just that we can do nuchal translucency only in this length. So, but please remember 11 to 13 plus 6. Now, this is a good, see, whenever we do a screening, our diagnosis is based on, our screening is based on a good NT scan. So a good NT can be taken by a person who's actually trained by FMF and accredited by FMF. So we cannot have a NT scan which is not done properly. So there are very strict criteria to have a good NT scan. And see, NT 0.1 millimeter difference also will make a difference in the final screening risk. So it is a very, very important aspect of our screening. We cannot use NT if it is not properly done. And if we use, we might just mess up with the final risk. So let us see a few cases. A second gravida, previous one live child, previous no living issue, and 28 years, double marker was done. So she did double marker, which was in first trimester. It showed high risk for trisomy 21. So it showed high risk for Down syndrome. So now option of invasive diagnostic test was given. She was not willing for any invasive test. So now it was a high risk, and option was given for invasive test, that is a chorionic villous sampling or amniocentesis, but she was not willing for anything. And she said, I'm willing to take the risk. So now, did we miss something here? Yes, we missed the pre-test counseling. So see, if the patient is ready to do any invasive test, then the method should be used. If she is ready to take the risk, then giving an apprehension and giving an anxiety by doing just a screening test won't help. So any screening test, we should be having a pre-test counseling. For women who do not want any information, we should respect that. And her decision should be respected. But yes, at the same time, we should be documenting it that she doesn't want any further testing. So it is pre-test counseling is a must when we are doing a screening test. So patient education point, we have to tell them this is a screening test, not a diagnostic test. It is optional. It is not mandatory. A negative result does not guarantee a healthy baby. And a positive result obviously does not mean that the baby has a problem. So that thing should be removed from their mind, that if a positive result comes, that means her baby is abnormal. No, but further testing should be offered to all patients, regardless of age. So that criteria of more than 35, less than 35 is no more into use. So it should be offered to all the patients. Now let us look at the second case. 28 years, primary gravida. She missed her first trimester screening. So she did the second trimester screen, which is usually done after 15 weeks. Now the second trimester screening showed high risk for trisomy 21 Down syndrome. Obviously, everybody was unhappy about the report because they never expect an abnormal report. Now repeat screening test was done. So now this was another mistake which was done. So they repeated the screening test. Almost after 1 week interval, the risk came as low, and now everybody is very happy. But are we correct? A big no for this. So we should not be repeating the test whenever we have an abnormal test. So we have to act on it, not just repeat it and see whether it's really high. So we should act on the report and not repeat the report. So do the test from a high quality lab so that we don't have to repeat for the quality purpose. Do not repeat the test and can repeat the calculation. So see, many times if we get the report and if you feel some factors were not included, you can always ask for a recalculation with the same values. So you should have the same blood values and you can ask for the repeat calculation, but do not repeat the blood test. So first trimester screening requires adherence to the standards and maintenance of quality in lab, also in ultrasound. Now let us look at the third case, primary gravida, IVF conception. Nuchal translucency on ultrasound was 3.5 millimeter. Counseling was done, CVS was done, and it showed a normal karyotype. Again, everybody is happy because the karyotype came as normal. It was an IVF precious pregnancy with high NT. Everybody was happy that it is not Down syndrome. Doctor and patients both were happy. Now we did an anomaly scan at 19 weeks, showed a major cardiac defect. Now again, an atmosphere which is difficult to handle for the couple, difficult to explain it to the couple, because they want an answer. Now that CVS was done, it was all normal. And now at 19 weeks, we tell them that there is a cardiac defect in the baby. So where did we go wrong here? We did not do a proper post-test counseling. So after any screening test, like how pre-test counseling is must, post-test counseling is also mandatory. So you should prepare the couple for any untoward consequence, so that they do not have this, they are not faced with a sudden problem at 19 weeks. So we should have told them that even with normal karyotype, NT of 3.5, there are possibility of having malformations, which we will monitor and see, and so that they are prepared for that answer. So any elevated NT, 6 times increased association of complex congenital heart disease. So normal is 2 to 3%, but with babies with high NT, the incidence increases 6 times. So an abnormal NT, you should always have a fetal echocardiography. So now let us look at the next case, a primigravida, spontaneous conception, monochorionic pregnancy, and opted for nuchal translucency. One fetus NT was 3 millimeter at 11 weeks. Invasive testing was done. It was normal karyotype. So with high NT in one baby, invasive testing was done and karyotype was found to be normal. Again, all happy about it. Scan at 18 weeks, evidence of TTTS. So in twins, we have to make them understand that apart from karyotyping, there are other problems which can come. So especially in a monochorionic twins. So we have to tell them that there is a possibility of twin-to-twin transfusion syndrome in twins. So increased NT is an early manifestation of TTTS in monochorionic pregnancy. So always high NT in monochorionic should not be taken as an indicator of aneuploidy, but there are definitely more things to that. So in multifetal pregnancies, first trimester screening can be used, but they should be made aware of limitation. So again, counseling. So counseling is a major part of any screening program. So what is the prerequisite for screening? Pre-test counseling. We should know the exact gestational age because all the calculations are based on the CRL of the fetuses. Mapping of fetus. So we have to locate in where in the uterus the fetus A or B is. So that if at all we have to do invasive procedure, we know where exactly we are going. We have to obviously be aware of chorionicity. We should not accept any report where they do not mention chorionicity. And we should have invasive diagnostic tests. So if doing screening will not have any purpose if I do not have the facility of doing an invasive test. So you should have the facilities to do an invasive test whenever you're doing screening. So in multiple, this table is little important table where you will see that maternal age can be used in any twins or higher order pregnancy. First trimester ultrasound NT can be used in both. Double marker twins can be considered but cannot be used in anywhere above twins. So you cannot use a blood test for triplet or any higher order pregnancy. Quadruple marker again can be considered but cannot be used in higher order. NIPT, there are no enough studies, though some labs are coming with NIPT in twins. So how to interpret pregnancy specific? So we know that in dichorionic, it is fetus specific. Each individual fetus we take and calculate the risk, whereas in monochorionic, the calculation is different, where we take the average of both the risk. Now another case, a second gravida, she missed first trimester screening. Second trimester screening was at 16 weeks. And she was screened positive for neural tube defects. So when we say a alpha fetoprotein for neural tube defects, she was positive. Now panic everywhere. So detailed anomaly scan was done because that is what is indicated when we have high AFP. But there was no neural tube defect. Now why was this? There was history of subchorionic hemorrhage. So whenever we have a subchorionic hemorrhage, we should expect a high AFP and we should not panic because AFP is high. There is no escape for a proper history taking. So any patient for screening, a good history is must. So if we would have a history of subchorionic hemorrhage, we know that AFP is bound to come high. So another case, a second gravida, spontaneous conception, first trimester screening was done, biochemistry was abnormal, and she was advised termination. She came for second opinion. Only the absolute values of blood test. So see, whenever we see a screening report, we should see that the test, the risk is not given based on the absolute values of blood. There should always be a risk calculation based on MOMs. So whenever we get an absolute value, they convert it into MOM and then the risk calculation is done. So absolute values were outside the normal range. Obviously, they give a range on the side and they see the absolute value. The absolute values were outside the normal range, but there was no risk calculation done and patient was asked termination. So should we go ahead? Absolutely no, we should not go ahead with termination because the calculation is not proper. All values should be converted into MOMs, NT also to be converted in MOMs, and risk calculation should be done only and only after MOMs. Now 43 years, IVF conception, singleton pregnancy, registered in second trimester. She missed first trimester screen. So she registered with us in second trimester and she missed her first trimester screen. Now see this report. Age written is 43. IVF written is no, whereas IVF was there. And see the risk. Risk is 1 in 257. So 1 in 257, I won't accept it as a risk screen negative because 250 is what we take a cutoff and I won't just be happy with 257. So this report came to me and the patients obviously were very panicked. Now see after correction, IVF, yes. Age, it was a donor egg. So the donor's age was not put in the previous report. Actual age of the mother was put, which was 43. So the donor age was 29. And see the risk, 1 in 6,271. So the risk calculation changes drastically and it is based on your history and the proper values which are put in the report. So age is very important. If it is donor egg, age of the donor should be put in the calculation and not the age of the patient. So factors which are considered is maternal age, maternal weight, parity, method of conception, ethnicity, smoking, diabetes, and previous baby with Downs. These are the factors which are considered when we calculate the risk. Another case, primary gravida, singleton pregnancy, first trimester screening was done, results were low risk. Second trimester screening, results were high risk. Now what next? So first trimester was done, she was low risk. The second trimester was done, it was high risk. Now, should we do an invasive test? So we cannot do a first trimester screen and also a second trimester. So this is an important point. Please, I want your attention for this slide, that we cannot have a first trimester screen separately and a second trimester screen separately. We are moving from a higher specificity test to a lower specificity test. So when my higher specificity test has told me that the risk is low, then there is no point going to a lower specificity test, which is a second trimester screen. Only if it is integrated screening, you can use both the risk. So please, if at all we are doing a first trimester screening, we should not be doing a second trimester screen individually. We can integrate both the reports, but individually we should not be doing it. So this is what combined first trimester. If it's screen positive, we offer amniocentesis or CVS. If it's screen negative, if it's integrated, use second trimester screening. So this is the rough values which we use, 1 in 100. See, many labs, doctors, we are using 1 in 250. But yes, 1 in 100 is the value. If it is risk is the risk is less than 1 in 100, so invasive testing or NIPT. If it is intermediate, you can offer them everything and they have to decide for it. And if the risk is low, there is no further testing. So usually you have 1% in high risk, you have 15% in intermediate risk, and more around 85% are low risk. What is integrated? I told you it can be full integrated or serum integrated, where you combine the first trimester and second trimester. You give the result only at the end of the second trimester. You don't give the result at the end of first trimester. So it is integrated risk assessment. Disadvantage, obviously they have to wait. It increases the anxiety. CVS cannot be done because you're giving the result in second trimester. And patients who choose not to continue with screening would be left with no result because we cannot give the first trimester result. Now, why trisomy? Why we talk about Down syndrome so much? Because it is very common. Because the baby can survive both in utero and ex utero. There can be no major abnormalities on ultrasound. So we can have a baby with no malformation and delivered as Down syndrome. And there is mental retardation, which is a social stigma. Now, see, basically what we see in first trimester is nuchal translucency, PAP-A, and free beta HCG. What we see in second trimester is AFP, estriol, and HCG. So this is these are the weeks of gestation where we use all these markers. So we can see that PAP-A, as gestation advances, goes high, free beta HCG, the graph goes down. On an average, baby with trisomy will have higher beta HCG and lower PAP-A. So this is in Down syndrome. See, the PAP-A goes down, NT and HCG goes high. Whereas in trisomy 13 and 18, everything goes high. And why have we chosen 11 to 13 plus 6? Because it is the prediction is best from 11 to 13 plus 6, and NT regresses after that. And the biochemistry markers that are used for first trimester are most sensitive. So they are most sensitive between 9 to 11. Advantage, we know it is higher detection rate, reassurance, we can do invasive testing, early termination. Social issues can be, because the stomach is not, the uterus is not seen, so they can handle it better, and there are lower complication rates. Disadvantages, because we know that even if we do not do anything, 30% affected fetuses die in utero. So they already die even if we are not doing anything about it. Limitations, they are dependent on the sonologist. Not all women enter prenatal care in time for screening. Results of screen may arrive too late, and extra cost for first trimester ultrasound. It cannot detect NTDs. So screening cannot detect NTDs. Still, we need serum alpha fetoprotein if we go for first trimester screening. So second trimester, these are the markers which we see, which goes high and low. Second trimester, Dr. Rasik sir, if at all I'm getting, it is getting delayed, please let me know. I'll stop in between. Dr. Rujul, is there time for me?
Another 5 to 10 minutes.
Okay, okay, fine, thank you. So second trimester screening, it limits prenatal diagnosis options, not as accurate for multiple gestation. Some labs do not offer calculation for twins. So that you have to please verify before you give it for the twins gestation, because some labs do not offer calculation. And the pros are, it includes NTD, neural tube defect screening, and it is often covered by insurance, which hardly matters for us. Now, this is the table which shows that if we use a full integrated, the false positive rate is low. Whereas if we use only first trimester, the false positive rate is 5. The detection rate is almost the same. So the combined screening, 82 to 87% with a false positive rate of 4 to 7%. And integrated, the false positive rate is very less. So this is a difference between the combined screen and the integrated screening. Now let us know a few words about NIPT, or which is known as basically non-invasive prenatal screening. So previously we used to call it as NIPT testing, but no, it is a screening test. So what we do is we evaluate or analyze the cell-free fetal DNA in maternal plasma. So we examine the cell-free fetal DNA which is present in the maternal plasma. We have to remember that it is again a screening test and not a diagnostic test. So it can be done as early as 5 weeks, and it gradually rises with increasing gestation. And the important thing is it is cleared quickly after the delivery. So that is important because it should not actually hinder with the next pregnancy. So it is cleared quickly from the maternal circulation, and it represents the current pregnancy. That is very important. When do we do it? Maternal age 35 years or older at delivery. If there is ultrasonographic findings indicating an increased risk of aneuploidy, there is history of prior pregnancy with a trisomy, and a combined screening result risk high. or there is a family history of a chromosomal abnormality. Now see the performance of NIPS. The false positive rate is very low, and the detection rate is somewhere around, for trisomy 21, it is 99%. So where NIPT should not be used. So this is very important when we have a late pregnancy complications, when we are screening for neural tube defects, when there are small variations in the genome, or there is atypical chromosomal abnormality, and it cannot replace an anomaly scan. Now let us see case. I have 5 minutes with me. So Mrs. S, 38 years, 18 weeks pregnant. She missed both her first and second trimester screen. Now ultrasound at 18 weeks shows a diaphragmatic hernia with single umbilical artery. So there is a major malformation. Now they did NIPT at 18 weeks because she has missed both the screening. Result came as negative. So the result of NIPT was normal. So are we all okay with this report? Answer is no. Whenever there is any structural abnormality on ultrasound, we have to have an invasive testing where we do microarray and fetal karyotyping. So a normal NIPT result is not going to help us in such cases where there is ultrasound abnormalities. So fetus with structural abnormality on ultrasound, any nuchal translucency which is more or equal to 3.5, or extreme values of combined first trimester screen. So these are the areas where we have to do an invasive testing. Now 34 years IVF conception, came for second opinion. NIPT was positive for trisomy 21. So NIPT was positive and she was referred for termination. That NIPT is showing positive, we want to terminate. So I explained her about the need for invasive test to confirm, and she was not ready and she was not aware of it. She never came back to me. So she was NIPT positive. When we asked her to do amniocentesis, she was not ready for it and she never came back. So what is wrong with this? Pre-test counseling. We have to explain them that whenever there is a positive NIPT, it has to be followed by invasive testing before termination. So we have to have an invasive test because false positive are there, can occur. So suppose we have n number of women having a high risk after CFTS. NIPT in all is n, 10 with NIPT positive. So 9 out of 10 will have Down syndrome, but one will not have Down syndrome. So invasive testing is recommended after a positive NIPT. Primary IVF with NT 3.5, NIPT done normal karyotype. Now anomaly scan at 19 weeks, again a defect. So post-test counseling again after NIPT is important. We will miss this, underwent NIPT. So life is like a multiple choice question. Sometimes the choices confuse you, not the question itself. And basically NIPT, the external factors are eliminated. We do not have any external factor, not indicated at present in multiple pregnancies, donor pregnancies, and vanishing twin. And newer panel are looking at deletions also. So these are the guidelines by ACOG and SOGC that triple screening obviously is out. Don't use age as a screening tool. Aim for higher detection and lower false positive rate. Consent and review. And regardless of which screening test, information about all the things about the screening test is must. And regardless of age, they should be offered all the screening. And using only maternal age of 35 should be abandoned. So a proper history, a proper NT, a proper calculation, and a proper counseling is what is very important. Screening is not only about aneuploidy, it is about much more than aneuploidy. And this is again my favorite quote, that if you make a diagnosis, even if it's a bad diagnosis, is more useful for patient and their families than having no diagnosis. But a wrong diagnosis is worse than a no diagnosis. Thank you very much for your patient hearing. Thank you.
Thank you, Dr. Shilpa, for this informative discussion on the role of screening, biochemical screening in both high risk and normal pregnancies. Madam has wonderfully highlighted the need for adequate counseling, the need for detailed ultrasound examination, and role of screening both in singleton and multifetal pregnancies. Thank you, ma'am. Thank you so much.
Thank you, Rujul.
We'll go on to our next topic, which is the first trimester ultrasound and dating scan. Dr. Rajani Krishnan, she is a senior consultant in the Department of Radiodiagnosis and Imaging at SRCC Hospital. She's been trained from BJ Pune and has special interest in obstetrics and fetal imaging. Thank you. Dr. Rajani?
Can you hear me?
Yes, sir.
Can you see my screen?
Yes. Yes.
Okay. Yeah. Good afternoon. I'm Dr. Rajani, and I'll be speaking today on the early obstetric scan and the dating scan. As we all know, the pregnancy has, on an average, lasts for about 280 days. And the first trimester is from the LMP to 12 weeks. This includes that period of growth, which includes fertilization, the formation of the blastocyst, implantation, the formation of the embryo, and early fetal life up to 12 weeks. Just a second. Sorry, Rujul, some technical problem. Just a second.
We'll wait, no problem.
Yeah, is it better now?
There's
Yeah.
one part of your screen which we're still not able to see clearly.
Second. Why is this not coming?
Rajni, you're in slide. Go to slideshow, the main slide on the screen.
On to the slideshow. I am on the slideshow. It's not going on further.
Put your cursor on the PPT, on the
Yeah, then
PPT
it's-
itself.
Yeah. Okay. Yeah. So in the first trimester, the 3 scans that are done are primarily the early obstetric or the dating scan, which is at 6 to 10 weeks. Then you have
Dr.
the
Rajni, sorry
Yeah.
to interrupt, but it is just go to the slideshow, na?
If you can just
Yeah.
click on slideshow.
Yeah, now? Why is this going off? Rujul, why is this going off? The screen is going blank all the time. Why is this happening? Slideshow? Yeah, slideshow is one. Why is this going blank like this? Okay, just hold on. The NTNB is yeah, that's the dongle. Seems like it. Is it there on your laptop? What is that? I'm sorry. Rujul. So we do an early OBS dating scan at around 6 to 10 weeks, followed by an NTNB at around 11 to 13 weeks, and then an early structural scan at 12 to 16 weeks. Now there's a set of normal sequential changes that should occur in an early pregnancy, intrauterine viable pregnancy, which we shall just see over the short next few slides. Pregnancy failure. And there are 2 ways in which we can do an ultrasound scan. either a transabdominal or a transvaginal. It's not working. See this. Constantly the screen is going off.
You put on some.
Yeah, put on a flat surface. In early pregnancy, the transvaginal scan is better than a transabdominal scan, primarily because it gives us better dating for the gestational age, and it gives us a better evaluation to rule out any ectopic gestation, early identification of multiple gestations, and we are more confident to diagnose chorionicity. The sequence of events that should occur in a normal early intrauterine pregnancy is firstly the appearance of a gestational sac with a double decidual sign, followed by the appearance of a yolk sac, then a fetal pole or an embryo, and then the demonstration of the fetal cardiac activity. Now, what is a gestational sac? This is seen as a small hypoechoic, well-defined cystic structure within the endometrial cavity. It is almost always eccentric in location, and there may be the presence of a double decidual sign around it. This would be seen up to 5 weeks, 0 days of gestation, and is obviously seen better on a transvaginal scan. The double decidual sign that you see is this difference in the echogenicity that is seen between the gestational sac and the surrounding decidua parietalis. However, if this double decidual sign is not seen, it does not mean that it is not an intrauterine gestation, or it does not mean that this is a pseudo-gestational sac. Just do a repeat ultrasound and correlate it with the beta HCG values. Once you've seen a gestational sac, the next thing that you look for up to 5 weeks, 5 days is the appearance of a yolk sac, which should be seen within the gestational sac. It should be smooth. It should not be more than 5 mm in size, and it should be regular and seen within. And in cases of multiple gestations, before you can actually see the chorionicity or the amnionicity, if you see more than one yolk sac, it corresponds with the number of amnions in the future. After which, from 6 weeks gestation and later, you should see the fetal pole. This is seen as a small echogenic structure eccentric on the yolk sac. And later on, you would get the appearance of the cardiac activity. This is typically called as a diamond ring sign because the fetal pole looks like the diamond along the ring of the yolk sac. Now, cardiac activity, when we measure it in early pregnancy, unlike in later gestation, we should not be using a power Doppler. We should use an M mode because less ultrasound waves are sent to the cardiac, to the fetus. Any gestation that has an fetal CRL of more than 7 mm must show cardiac activity for you to declare that it is a normal intrauterine pregnancy. So these are the sequence of events that you should be seeing in uterine pregnancy: the appearance of a gestational sac with a double decidual sign, followed by appearance of a yolk sac, followed by appearance of the yolk sac embryo complex, and then demonstration of cardiac activity. You get a CRL, that is a crown rump length of 7 mm, but there is no fetal heart rate. Or if there is a mean sac diameter of more than 25 mm, but no demonstrable embryo or fetal pole. Or you have seen a sac without a yolk sac within it, and more than 14 days later, you still cannot see an embryo with a detectable fetal heart rate. Or you see a sac with a yolk sac, but no demonstrable embryo with fetal cardiac activity more than 11 days. These are definitive signs of intrauterine pregnancy failure. Now, what are the suspicious signs of failure? When you see a CRL of less than 7 mm, but there is no demonstrable fetal heart rate. When you get a mean sac diameter of 16 to 24 mm, but no demonstrable embryo. Or there is a sac without a yolk sac seen within it, and 7 to 13 days or more, you still cannot demonstrate an embryo with a heartbeat. The patient is definitive of her LMP, but it is more than 6 weeks later and we cannot demonstrate an embryo. Or you see an empty amnion, a large yolk sac, a small sac in relation to the embryo, then these are suspicious signs, and in such cases, you should ask for a follow-up. So if you see a suspicious sign, which is not diagnostic, you must ask for a follow-up, and on the basis of just one scan, you cannot label it as an early pregnancy failure. Blighted ovum is a form of an early pregnancy. This is a term that is not used anymore now. The term that is used is anembryonic pregnancy, in which there is a gestational sac, but an embryo does not form with it. And a missed abortion is one where the patient has no symptoms of a miscarriage, but there is a non-viable fetus when you do the ultrasound scan. So now, what is a pregnancy of unknown location? This is when the pregnancy test is positive, but when the patient comes for an ultrasound, the ultrasound reveals a normal pelvic ultrasound with no signs of an intrauterine pregnancy, and the adnexa is normal. What are the possibilities? In such a case, the possibilities would either be a very early pregnancy, that is when it is less than 4 weeks, 3 days. So it is cannot yet be detected on ultrasound. Or there is a non-viable intrauterine pregnancy, which again has not been detected. Or there has been a complete miscarriage and the patient is unaware of it. Or there is a very early, unidentified early ectopic pregnancy. In such cases also, we would ask for a repeat beta HCG level and a repeat short-term repeat ultrasound examination. Now, the other possibility that you would see is an ectopic pregnancy, which is a topic which is large on itself and out of the scope of this topic, but basically it occurs when the fertilized ovum is implanted somewhere outside the uterine cavity. Now, this is the sequence of events that occur in a normal intrauterine pregnancy. So what is an early dating scan? A dating scan is basically an ultrasound examination which is performed to establish the correct gestational age of the pregnancy. Apart from these, you also get information about the number of fetuses and the gestational sacs, the presence or absence of a heartbeat, the size of the fetus, and unusual features of the uterus such as fibroids or any other structural abnormalities. What is the importance of a dating scan? It helps to plan the future antenatal scans that would be needed, to schedule or interpret any further antenatal testing, either laboratory or radiological, in later pregnancy to determine the growth of the fetus, whether it is less or whether it is more. And if any of these are abnormal, then to plan correctly for any future expected interventions. Now, what we normally do as radiologists is that when a patient comes, the scan is entered, we feed in the LMP as per how the patient remembers. But this is a little bit dicey because the patient may not accurately remember her LMP. She may have irregular cycles, or very simply in that particular cycle, the ovulation may have varied in timing. And considering the LMP that we have fed in, when we complete the scan and print out the report includes the LMP given by the patient, the calculated gestational age based on that, and the EDD based on that. It also gives you the ultrasound calculated gestational age and an EDD by the ultrasound calculated age. Now, in case of IVF, when you know that the embryo transfer date is clear, then you put that instead of the LMP and change the data accordingly, as in the case of a follicular study, where the variability is plus minus 3 days. When you're using ultrasound to calculate gestational age, in the first trimester, use CRL, and in the second trimester, it is a combination of factors, primarily the BPD, the biparietal diameter, the head circumference, the abdominal circumference, and the femoral length. Now, the earlier in pregnancy that a dating scan is done, the more accurate it is. And especially when it is done less than 14 weeks, CRL is the most accurate. Especially in India, when a pregnancy comes without an ultrasound examination before 22 weeks, then such a scan must be considered suboptimally dated for future antenatal care. This is just to show that there are discrepancy between the ultrasound calculated age and the gestational age as per the LMP. And the earlier in pregnancy that it is done, this discrepancy is that much lesser. It is least when the first scan is done less than 8 weeks, 6 days, and it is the most when it is done after 28 weeks. Now, if a patient is unsure of her LMP, then dating must be based on the ultrasound estimates. Ideally, when you do it in earlier gestation, depending on CRL, that is the most reliable. When the gestational age by ultrasound matches the biometric age by the LMP, then the EDD that is written on the report is as per the LMP. But if there is a discrepancy between these two, then the report, the EDD that is written on the report would be as per the ultrasound. Let us take this example. A patient comes with an LMP of 3rd of January, with an EDD by the LMP of 10th of October. By ultrasound, she's coming to 12 weeks, 4 days, which gives an EDD of 12th of October. Now, the difference between 10 and 12 is just 2 days. This is less than 6 days. So on this report, the EDD that we printed is 10th of October, not 12th. But in this case, where again she has an LMP of 3rd, but the gestational age is coming 11 weeks, 3 days. That means the difference between 10th of October and 20th of October is more than 7 days. This is a 10-day discrepancy. Then when this patient's report is printed, the EDD on the ultrasound report is given as 20th of October, not 10th of October. A pregnancy that is dated earlier has an accuracy in calculation of the EDD of plus minus 7 to 10 days. This becomes more and more as the pregnancy progresses. And a pregnancy without an ultrasound examination, which either confirms or revises the EDD before 22 weeks, must be considered suboptimally dated. Now, what is the importance of doing this and stressing again and again that it must be entered on the record? After a dating scan, when this EDD has been entered once into the antenatal record, it cannot be changed on any subsequent scans. The mother must be made aware of this date assigned. Either tell her very clearly that this has been reassigned as per your ultrasound calculation and whether it is matching her LMP EDD or no. And she must be told that in all future antenatal scans, she has to bring this report with her. Basically, in subsequent scans, we should not be giving different EDDs as per that ultrasound, because we've seen in previous slides that as the pregnancy gestation increases, the variability in the EDD also increases. Giving two EDDs, like printing the EDD by the ultrasound and EDD by LMP, is not done. And especially in the first trimester, we must use the CRL for dating, not the MSD. So when a patient comes for the subsequent scan, first of all, we must look at all the previous reports and find which is the first scan report. If there is a discrepancy, especially on this current scan, look for the old EDD and check whether that EDD was reassigned or no. If it is a reassigned EDD, go back to the patient's entry data, enter the reassigned EDD. The machine will back calculate and tell you what is the expected gestational age. And then you can confidently say that, yes, there is a difference in growth of this fetus or no. This is how a report should look. Single live intrauterine gestation of 8 weeks, 0 days, expected by LMB 9 weeks, 3 days with delayed conception. No abnormalities seen at present and assigned EDD of 9th of December. In this report, the EDD has been reassigned as per the ultrasound. Only one EDD must be given in this report, not two EDDs and not the old LMP EDD. The next time that this patient comes for a follow-up, do not use her LMP to enter the data into the system. You must use this assigned EDD, so it will correct the calculated expected gestational age correctly. So, in conclusion, what I would like you all to remember is that there is a normal sequence of events in a pregnancy, intrauterine pregnancy, that should occur in series for you to diagnose it confidently. If you are going to diagnose intrauterine failure, there must be definitive criteria. If there is any suspicion, then always ask for a follow-up, and on the basis of just one scan, do not label it as a pregnancy failure. A dating scan is best done between 6 to 10 weeks when we measure the CRL, which gives you the most accurate fetal age. Assign the expected date of delivery cautiously after seeing your records. Once this EDD is assigned, do not change it on subsequent scans. And whenever a patient comes for a follow-up, always look for the dating scan to confidently correctly diagnose growth disorders. Thank you.
Thank you, Dr. Rajani, for the detailed discussion on the very first scan of a pregnant couple. She has in detail discussed the importance of the first trimester ultrasound, that is a dating scan, with respect to it being to be done accurately and documented properly. Ma'am, I have one question for you. Ma'am, we often get reports very early as a 5-6 weeks. We see a small subchorionic collection. The ultrasound report says that there's a small subchorionic collection. Ma'am, so these patients, when they ask, what would you want to advise them while just after completing the scan? What would you
Yeah, see, you look at the other features that are there apart from the subchorionic collection, how big it is, and whether the sac itself is normal, whether the yolk sac has come, how is the yolk sac, what is its shape, before you label it as something that needs to be worried about. And always ask for a follow-up ultrasound. Ask for a serial beta HCG, ask for a follow-up ultrasound, and clinically see whether she has any spotting or anything like that before you label it as pregnancy failure.
Okay, ma'am. Thank you so much, ma'am. Our next speaker is Dr. Pooja Vazirani. Madam will be speaking on the first trimester scan. Madam is a senior fetal medicine specialist trained in fetal medicine at Mediscan, Chennai. Ma'am is currently working at LH Hiranandani Surya Hospital and SRCC Hospital. Good afternoon, ma'am.
Thanks, Rujul. Good afternoon, everybody. Thanks to Shilpa and Rajani, who have covered the previous two topics so fantastically, so that we can go into deeper aspects of the screening. So the credit for the first trimester screening goes to the father of fetal medicine, that is Professor Kypros Nicolaides, who actually has tilted the pyramid of care into upside down. And that's why we are straining a lot on the early pregnancy scans. That is the 11 to 13 plus 6 week scan. Nevertheless, as Rajni said, a dating scan in the early pregnancy is also very useful if patient is not getting the access to these scans. So basically the 12-week scan or the 11 to 13 weeks plus scan is basically to triage fetuses into high risk or low risk fetus and a high risk or a low risk mother. Fantastically again covered by Shilpa. And next step would be accordingly on the triaging, they'll be going into different categories, that is directly to the anomaly scan and then to the growth scan, or in between, referring to a specialist if needed. So coming to the first trimester screening, it's done between 11 to 13 plus 6 weeks. If you want to accurately say, it's done between the CRL, that is the crown to rump length, of 45 millimeters to 82 millimeters, because the 84 now corresponds to 14 weeks. So we are going to cover the other aspects apart from dating, that is screening for common aneuploidies, screening for structural defects, screening for preeclampsia and fetal growth restriction, and screening for multiple pregnancy and risk assessment. So these are the important screening modalities at this scan, the one-stop scan. So the revolution in this week is the screening for aneuploidies, and nothing better than the nuchal translucency, which is indeed a boon for the FTS program. And therefore, it forms one of the most important scans for every pregnant woman. In the screening for aneuploidy, we consider the maternal age, the fetal heart rate, most importantly, the ultrasound markers, where the nuchal translucency carries the lot of weightage on that. The other markers like the nasal bone, ductus venosus, tricuspid regurgitation, and the biochemistry, that is the PAPA and the beta HCG levels, are included. The most important, again, to be remembered by everyone, it's not screening for beyond 35 years of age. It should be screening for all the women. Why? Because you'll be picking up nearly more than 50% of trisomies, and including the early pregnancy and the later gestation. Why is that so? Because the reproductive age group will have more number of babies. So if you screen only women beyond 35 years, you will be missing this lot. And that's why this screening is for everyone, the entire population. Nuchal translucency is nothing but a subcutaneous accumulation of fluid, which appears like an equilucent line near the neck of the fetus. The size of this nuchal is very more important than the appearance, like septations. And I said, there are certain strict criteria laid down by the Fetal Medicine Foundation, which has to be remembered while you do the scan. And that's important for proper risk assessment as well. Sorry. So if you get a screening result, that is the first trimester ultrasound report, this is the image which everyone needs to understand who uses the scan for interpretation and counseling for the mother. That is, the nasal bone should be seen. It should be a proper mid-sagittal view. How do you understand that? You get the tip of the nose, you get the skin, you get the equal to sign of the nasal bone. You get the maxilla, which is appearing like a rectangular echogenic area, a dot of the symphysis menti, a fluid between the neck and the chest, the equilucent line, the nuchal translucency behind the neck. In the head, the midline structures like diencephalon, the future thalami, the intracranial translucency, which we'll be discussing. So this is a proper mid-sagittal view. Zooming should be 75% of the head and 25% of the thorax. A very important thing when you see these scans, this image should be there. Unless you see such an image, the sensitivity of the entire program drops. Nuchal translucency it's so important, and we are going to talk more about this because every value of nuchal represents a likelihood ratio. The lesser the NT, the lesser the chance of chromosomal abnormalities or structural defects. The higher the NT, as you see here, you have more chances of structural abnormalities, genetic problems, and genetic syndromes as well. So this is the 5th to 95th centile of the nuchal translucency from the CRL of 45 to 85. And this group has majority of the non-chromosomal fetuses, or you can say the euploid or normal fetuses. Whereas few cases of common trisomies will be seen. However, once the nuchal rises beyond the 95th centile, the chances of having common aneuploidies will start increasing. And you can see the topmost turners will have the largest NT of all. The next marker we'll be covering, we have to cover the structural defects also. So we'll be talking in brief about this other markers, that is the nasal bone. Again, the same image what you take for nuchal will be required for your nasal bone. It's an echogenic line just below the skin, like an equal to sign. It requires a proper position so that otherwise you will miss on this marker. And it's a very tricky marker. If not confident, don't mention it in your first trimester report. However, if you're expert, you're trained into it, do mention it because it's a very important marker apart from the nuchal, as 70% of fetuses with Downs will be carrying no ossification. That is, you'll be seeing an image like this where there'll be no equal to sign. That is the no ossification of nasal bone or the absent nasal bone. Mind it, it's not the absence of nose, it's the absence of the nasal bone. And that should be important. And this is a fetus which has increased nuchal as well. So definitely high risk for chromosomal defects. The next hemodynamic marker, the other two markers which we are going to talk is ductus venosus and tricuspid, and both are hemodynamic markers. The ductus venosus is a small vessel connecting the portal vein to the IVC, has a mosaic-like color pattern and easily identifiable. The caliper, these are certain, again, a very strict criteria in the Fetal Medicine Foundation. That is, the sample gauge should be 0.7 mm, and the waveform will be like an M pattern with positive flow in the diastole. And that's what ductus is all about. Why is it important? Because it not only tells us that the fetus is high risk for chromosomal abnormalities, but because of its hemodynamic marker, increased risk of cardiac defects are also seen in these fetuses and fetal death as well. Now, when is fetal death common with ductus venosus reversal? That is, you will get an A-wave reversal going below the baseline. It is when you have a very low PAPE on your biochemistry, women of Black origin, and high BMI. And therefore, all cases of ductus venosus reversal, if the baby is genetically normal, do require a growth monitoring as well as uterine artery monitoring to rule out future evolving placental dysfunction. Tricuspid regurgitation, again, a hemodynamic marker. Again, there are criteria in the FMF to see this tricuspid regurgitation. You need a 4-chamber view, the sample gauge should be 3 mm, and the velocity should be more than 60 centimeters per second if you want to say it's a tricuspid regurgitation. As you can see, it's again a hemodynamic marker, so no doubt about it. It's going to tell us more about cardiac defects as early as 11 to 13 plus 6 weeks. And this is a fetus with cardiomegaly, pericardial effusion, and has a tricuspid regurgitation as well. So both these markers, if you add in your screening test, they will raise the detection rate from to 95% with the false positive of 2.5%. And Shilpa has explained what is this false positive rate. So the combined screening is the norm. Please do not stop with maternal age. Please do not stop with only serum screening, and the serum screening at 15 to 18 weeks, that is the triple marker, is outdated, not to be used. If ever has to be used, it should be quadruple. But if accessibility to good evidence-based care, please include the maternal age, the nuchal translucency, the nasal bone, the biochemistry with beta HCG and PAPE at the 11 to 13 plus 6 week scan, you can add your DV, that is the ductus venosus, and tricuspid regurgitation to reduce the false positive rate. The next aspect we're going to cover is the screening for structural defects. And the nuchal again here becomes very important, because an increased nuchal translucency is not only a marker for Downs or a chromosomal malformation, but also is a pointer to structural defects, especially cardiac, genetic syndromes, skeletal dysplasias, and fetal infections. In the year 2013, the very prominent body, that is the International Society of Ultrasound in Obstetrics and Gynecology, has laid down the guidelines for performing this first trimester screening with an entire checklist from head to toe. And this has to be covered if you are generating a scan for first trimester screening. And definitely it improves the reporting, gives a good picture to the patient as well as to the obstetrician. We start from head to toe. You can do it in the mid-sagittal view as well as the axial view. What is the biometry which has to be included apart from your crown to rump length is your head circumference, is your abdominal circumference, your femur length. These two, however, are optional. The head circumference is important because you rule out anencephaly, which is the important, very, very strong abnormality in the first trimester. So when you see the head, the skull, the midline falx, and the choroid plexus needs to be imaged and documented. And why is that so? Because merely by seeing that, you rule out the dreadful anencephaly acrania sequence, large encephalocele, alobar holoprosencephaly, and sometimes you can have posterior fossa defects. Now, 1, 2, and 3, these are the most important abnormalities, should never be missed when you're doing a first trimester screening, because they're always detected. I'm going to include this marker in the head. Why? Because it's a marker which is seen in the head, but an indirect marker for ruling out open neural tube defects. And thanks to the pioneering effect of Professor Ravi Choi, who came out with the assessment of intracranial translucency. That is nuchal, that is NT, and this is IT at the 11 to 13 plus 6 week scan. The same view which you use for nuchal translucency should be used for seeing this. Here is the diencephalon. Then comes the brainstem. This is an echolucent line here. Again, an echogenic line in between. This echolucent line is the future fourth ventricle. This echogenic line here is the choroid plexus, and beyond this echolucent is the cisterna magna. So you have 3 echolucent lines and 2 echogenic in between. So that's the brainstem, that's the future fourth ventricle, and this is the cisterna magna. The hallmark indication that the baby does not have open neural tube defect by merely seeing these 3 echolucent lines. So definitely it's the paradigm shift from detecting the dreadful open neural tube defects in the second trimester to the first trimester. This was the first trimester 12 weeks fetus. There are only 2 echolucent lines. There is no proper 3 line demarcating that. Suspicion of open entity was made, and thus a thorough imaging of the spine. And you can see the open neural tube defect in 3D, and this is in the 2D, as well as here as well. Now, when you do, what the mind knows, the eyes will see, and therefore more and more studied into this. Actually, from the 2 echolucent lines, they were seeing 3, but the center one was quite enlarged. And that gives that if this is the future fourth ventricle, why is it so big? And then came the diagnosis of increased intracranial translucency rather than absent. And this was again a very, very good innovative paper in the year 2014, because it again tells us that something is going to be wrong in the posterior fossa, needs monitoring at 16 weeks. And this was the same baby followed up and had a huge severe ventriculomegaly as early as 16 weeks. Then comes the face imaging with the orbits and the maxilla. Retronasal triangle, which includes the 2 dots. These are the nasal bones. You have 2 nasal bones, the zygoma, and then you have the maxilla, the hard maxilla. This excludes your hard cleft lips and a hard cleft palate, and along with that cleft lip. 2 orbits need to be seen with their respective lenses. This was a case, you can see the mid-sagittal view is absolutely distorted. These are the orbits, hypertelorism, This is the premaxillary bulge. This shows that it is a bilateral cleft lip and cleft palate. So merely by including these two images, you have a diagnosis of so many abnormalities which are nearly very, very high likely to have aneuploidy, especially trisomy 13. The next hallmark paper came in by Professor Chavi again, that is the maxillary gap at 11 to 13 weeks. Here we see the same image again for the nuchal. So it's quite easy. Once you are trained enough to get this image, one by one, you start getting trained for diagnosing other major abnormalities. So this is the maxilla, which is a long triangular echogenic area. Any break in that will give you a suspicion of the cleft lip and palate. And this is a partial one. And you have absence of the maxilla. There's a complete large cleft with the protrusion of the mid-maxillary or the soft tissue. Fetus with enlarged nuchal, bilateral cleft lip, cleft palate, head showing aloe-haloperism-kyphale, hypotelorism, no doubt has to be trisomy 13, which was proved by the Chorionic sampling. Then comes the thorax, where you need to see the situs. Now that's very important. The cardiac screening has again changed. People used to think that the cardiac screening can only be done at 24 weeks. Then it came to the anomaly scan level. And now it's as early as 12 weeks. So this is the abdomen section where you'll be seeing the stomach. You see the situs, it's on the left, apex of the heart on the left. So that's important to see the situs. Along with that, you'll be seeing the four-chamber heart, the lungs on each side, absence of any fluid or malformation over there. Again, Professor Chow had a classic paper on the first trimester screening of the heart, whereby we don't give more importance to the B mode because it's a tiny structure. You cannot exclude a lot of details, but definitely the color flow, that's two red going in. So you can see the patency of the AV valves, two blues coming out, and these are the arches. This is the ductal arch, this is the aortic arch. So major abnormalities of the heart will be ruled out by this beautiful view in color. Additionally, to diagnose these cardiac defects, the markers are reversal of flow in the ductus venosus. As we said, there was a case of a pleural effusion, cardiomegaly, and hypoplastic left heart. There was a single outflow seen at 12 weeks. This was the four-chamber view, or the three-vessel trachea view with a color view, showed only a single vessel over here. The AV valves and the four-chamber view was fine. This is confirmed at 16 weeks to have a double outlet right ventricle with pulmonary atresia at 16 weeks. It was Downs when we did the amniocentesis. Again, 12 weeks suspicion of having a parallel OT, again called at 16 weeks, and it was confirmed. This was transposition of great vessels, confirmed at 16 weeks and following up. This was a primary gravida who had high risk for trisomy 13 on the double marker. She went for NIPS first, again high risk for trisomy 13, came for a second opinion, and there the baby showed multiple abnormalities, AVSD, a univentricular heart, and definitely there was a retrograde flow in the aortic arch. She had to do the CVS, and it came out to be trisomy 13, which was positive. So this, what Shilpa was saying, that when you have anything on your ultrasound which is abnormal, NIPT goes into the dustbin. You have to do a invasive testing, which Shetal is going to take forward on it. The other case was having a normal nuchal. However, there was a suspicion of a ventricular septal defect. Why am I saying it's suspicion? Because you don't label the cardiac abnormalities at 12 weeks. You do call them at 16 weeks for a confirmed diagnosis, because they can be treated and repaired. That is, this was confirmed to be a tetralogy of Fallow, which was suspected at 12 weeks because of the narrow ductus arteriosus. And tetralogy of Fallow has a very good outcome if you're in good hands. There was no microdeletion for 22q. CVS was done. The other karyotype and the microarray was normal, and the child has continued. This was a case where the previous child had cardiac abnormality. Now, whenever you have previous child with cardiac abnormality, definitely you'll be looking at the heart in more in detail at the 11 to 13 plus 6. Luckily, thin patient. Look at the chamber anatomy at below 60 mm or 70 mm of your CRL. And this baby had a double, right aortic arch. There was a partial vascular ring. Again, a CVS is required because it's associated with 22q microdeletion, had normal and has good outcome. Continued the pregnancy. Now, when you're looking at the thorax, as I said, you should look into the lungs as well. Now here, this was a four-chamber view of the heart. The apex of the heart is pushed. if you see a lot of babies, you will definitely identify the shift of mediastinum as early as 12 weeks, and that had the small bowel there, a part of the stomach over there. This was confirmed as a congenital diaphragmatic hernia. Both the cases, because so early in onset, the parents didn't want to continue the pregnancy. And of course, one had a genetic abnormality as well. When we come to the abdomen, you can see it in the mid-sagittal view as well, and the transverse section, which is the best to identify the cord insertion area in the fetus to rule out omphalocele and gastroschisis. The coronal view will show you the bladder, the equilucent area, the stomach, and of course, you will see the two umbilical arteries on either side of the bladder. What do you do? What do you rule out by this? Now, this was a case with, okay, a prominent nuchal, not so high. Definitely the nasal bone was not seen clearly. The posterior coronal view had this kind of a cystic area. Since the bladder was seen very well, now this was a high suspicion of evolving inorectal malformation, especially when you don't have you have one marker and the other is prominent. And this, the patient was counseled and CVS was done and was found to have trisomy 21. And it is known that if you have a cystic area in the lower abdomen, more posterior to the bladder, you can suspect inorectal malformation as the baby proceeds. Again, you will be diagnosing omphalocele, large omphalocele, small ones with bowel, gastroschisis, and multisystem abnormalities also can be diagnosed, combining all the anatomy in action. Syndromes, a very large bladder, that is megacystis, can be due to obstruction or can be a non-obstructive cause. Prune belly syndrome is labeled to see large bladder distending the entire abdomen. Again, this is a complete different topic and will take us to all, but these are the possibilities you will be able to diagnose when you merely see the bladder on your 12 weeks. Coming to the skeletal structures, all the limbs, upper limbs and forelimbs, and all the three sections should be seen in the fetuses, because these are major abnormalities and always detectable. That is, a transverse limb defect should not be missed in the first trimester and should be counseled accordingly. Spine, again, you have seen the indirect sign for the open neurotube defect, but definitely you to add to a feather in your hat, if you include a good imaging of the spine as well, you rule out certain other problems like a hemivertebra as early as 13 weeks, again to be called at 16 weeks for further checkup and counseling. Talipes can be diagnosed. Again, transverse limb defects, club hands, club feet, and definitely polydactyly when seen should be kept in mind, trisomy 13, 18. And when it is combined with a kidney issue, then definitely polydactyly in all the limbs, encephalocele, and non-functioning kidneys as the bladder is absent can go into a syndromic diagnosis of Meckel-Gruber, which has a 25% recurrence rate. So, in addition to a bladder, usually it's enough to see the bladder with the umbilical arteries on each side. But if you're imaging transvaginally, you may see the beautiful kidneys on each side of the spine, can add to your checklist for anatomy as well. So what does systematic imaging helps? It helps us to identify fetus with structural defects, which are related or non-related to chromosomal abnormality. You can suspect a fetus with an evolving abnormality, and therefore she needs to come at 16 weeks rather than straight a 19 to 20 week scan. It can be a syndrome or a single gene disorder, and accordingly invasive testings and the test needs to be done. So we need to understand there is a complete paradigm shift in assessing these abnormalities. Systematic imaging, early termination for fetal abnormalities, early identification, proper counseling, and diagnosing recurrent defects, which are important, are part of this scan. The next is the screening for preeclampsia. Now, this is also equally important because, in fact, more than downs, we have 40% of the primary gravidas in Indian scenario to be affected with preeclampsia, which is again a very, very big cause for maternal mortality after PPH. And this first trimester screening will help you in that. Now, the ISWOC had published the ASPRE trial, which is the role of aspirin in prevention of preeclampsia, where they included maternal factors, a checklist of all: high BMI, age, smoking, previous diabetes, hypertension, preeclampsia in mother, sister, or all the maternal factors which are important. The mean arterial pressure was taken, the uterine artery Dopplers were taken, and PAPE and the placental growth factor These two hormones are very, very important in prediction of preeclampsia and fetal growth restriction. So when they included all this in women with single-tooth pregnancies, and when the risk assessment in their software comes to be more than 1 in 100, then definitely they are high risk for preterm preeclampsia, which is again a very, very important aspect, because we get a lot of preterm IUGRs, NICU admissions. There's a whole list of abnormal problems or morbidity IUGR fetus has to go through. So when you identify this in the 11 to 14 weeks, you can help them by providing them an aspirin, which is 150 milligram per day at bedtime till 36 weeks. And it reduces the incidence of preterm preeclampsia by nearly 60%, which is absolutely fantastic, which is not only 60%, some studies do say it's nearly 70 to 80%. The NICE guidelines and ACOG guidelines, they recommend only aspirin based on the maternal factors or other history, but they didn't include all 1, 2, 3, and 4. So they could detect only 39% of their population with a preterm PE. So this is definitely the norm now. If you really want to do a one-stop clinic for all, that is aneuploidies, structural defects, preeclampsia, and FGR screening in the 11 to 13 plus 6 week scan. The last but not the least, there's a full array, but limited time, so we're going to just brush on these points. Screening for multiple pregnancies, again, the 11 to 13 plus 6 week scan is the scan where you need to put the chorionicity. It is a must, and this is still not being put in many ultrasound reports. Obstetricians should not agree with only a twin scan, twin scene, 2 fetuses and 2 sacs. No, it has to mention whether it's a dichorionic pregnancy, which has a lambda sign of that is the chorion invasion in between the membranes, or it has a T-shaped membrane, which is the sign of the monochorionic diamniotic twin pregnancy or the higher order gestation. Dichorionic and monochorionic have to be mentioned separately, clearly, so because they both are different in their course for surveillance as well. So you have to diagnose chorionicity, you have to accurately number and label these fetuses. The first trimester screening and the biochemistry is only applicable if you want to do a good screening for twin gestation, whether it's dichorionic or monochorionic. Triaging them into high risk, the monochorionic group, and low risk, the dichorionic group. And accordingly, managing these fetuses where there's a complete guideline on how do you manage a twin gestation based on chorionicity. Also do mention about discordant CRL, discordant nuchal, structure, fluid, and Doppler if needed. Appropriate surveillance in monochorionic. You will be counseling the couple whenever you see this monochorionic twin pregnancy there and there. That is 85% are going to be fine. 15% may land up with multiple problems which are specific to monochorionic pregnancy. So thank you so much for the patient hearing, and thank you SRCC, and we are proud that SRCC is now a one-stop area where we have fantastic senior fetal medicine. We all are there, and perinatologist, and so many fantastic pediatric surgeons ranging from cardiovascular to other specialties. And this is going to be covered entirely in the perinatology team or the fetal medicine team. So thank you so much for this opportunity.
Thank you, Dr. Pooja, for this excellent and illustrative presentation with such wonderful images. Madam has very well highlighted the significance of the first trimester scan, the role of antenasal bone and other soft markers, and all this not just for the diagnosis of chromosomal aneuploidies, but also for structural abnormalities in every body system. Our next, thank you, ma'am. Our next topic is on invasive testing, that is amniocentesis and chorionic villus sampling. This topic will be taken by Dr. Shetal Mehta. Ma'am has completed her MS in Obstetrics and Gynec from St. GS Medical College. She's been an ex-assistant professor at KEM Hospital. Ma'am has completed a fellowship in fetal medicine at Mediscan, Chennai, and a research fellowship at Mount Sinai Hospital in Canada. Ma'am is currently a fetal medicine consultant practicing in Mumbai and an honorary consultant at Comprehensive Thalassemia Care Center in Mumbai.
Thank you, Dr. Rujul. So diving right into the diagnostic prenatal procedures that we do. So basically, we'll be talking about only the diagnostic prenatal invasive procedures, because the therapeutic ones will be dealt with in the next talk. And we'll be discussing the choice of the procedure, which is usually based on timing, and the indication and the expertise of the person offering the procedure. Most of my talk is based on this very helpful issue or guideline, which tells us the do's, don'ts, and gives us a checklist as far as these invasive procedures are concerned. So beginning with amniocentesis, it's simply the trans-abdominal aspiration of amniotic fluid, first performed since, or has been performed since 1970s. It is usually, or rather it should only be offered after 15 completed weeks, because early amniocentesis, which was done earlier, between 12 and 14 weeks, has a higher loss rate, a higher chance of amniotic fluid leakage, and a higher chance of fetal deformities like fetal talipes. So about the technique, it's usually a trans-abdominal procedure performed under continuous ultrasound guidance. A spinal needle of number 20 to 22 gauge is used. I usually prefer the 22 gauge needle. The idea is that when we try and puncture the amniotic cavity, we should avoid the placenta as much as possible, and most definitely avoid the placental cord insertion. If not, at least in Rh negative women, we must take extra care that we avoid going transplacentally. Whether or not you avoid the placenta, the fetal loss rates don't differ. But if you go through the placenta, it increases the chance of a bloody tap, and hence it increases the chance of sensitization, and also increases the chance of maternal cell contamination, which I'll talk about later. Whenever we do the procedure, we usually discard the initial 2 ml of fluid that we aspirate, so that any maternal contamination that has occurred can be dealt with. The amount of fluid that you aspirate is anywhere between 15 to 30 ml of fluid, depending upon the gestational age, the number of tests that needs to be run, and what the amount of amniotic fluid that's actually there around the fetus. Usually the rule of thumb that we follow is it's safe to aspirate 1 ml per gestational week. So once we put the stylet, once we put the needle in the amniotic cavity, we remove the inner stylet and then attach a syringe and aspirate the amount of fluid needed. This aspiration can be done either by the operator themselves or an assistant, or sometimes a vacuum aspirator. So this is an image showing how this is the uterus. This black that you see is the amniotic fluid. This white structure at the corner here is the placenta. That's the fetus. So that's the needle which comes through the maternal abdominal wall, pierces the uterus, enters the abdominal cavity, and then once the needle is seen safely in the cavity in a placenta-free part, we remove the needle and attach the syringe. And then when you aspirate, this is how an amniotic fluid looks like. These are the needles that are typically used in all diagnostic invasive procedures, starting from the bigger to the smaller gauge. So number 18G is the higher gauge needle, which is usually kept for CVS. It's a pink top needle. And number 22 gauge is the one which we use for amniocentesis. It's got a black top. Along with this length, you get the needles at slightly bigger lengths also, where the gauge is the same, but the length is longer, which may be needed sometimes depending on conditions like maternal obesity. So when we send amniotic fluid for testing, there is an inherent property by which in 0.1 cases, so 1 out of every 1,000 samples, there's a chance that you get a report which says that there is culture failure. So what essentially it means is that they could not get adequate amniocytes or the cells inside the amniotic fluid to give us any valid karyotypical information in that particular case. The chances of these kind of reports coming back. So basically what happens here is we have done a test, but we have nothing to tell the patient. There is no reports that we can give the patient. The chance of that increases if when we do an amniocentesis and that we see that the fluid is either blood stained, either fresh blood stained or old blood stained because of a past hemorrhage. So the moment you see that, you have to remember and document it, because the chances of a culture failure are higher. Also, the chances of culture failure are higher when the procedure is done later in pregnancy, more so after 28 weeks. There is another kind of report that you get, which is mosaicism. Mosaicism basically means that there are 2 separate types of cell lines that you see in the given sample. So let's say there are a few cells which are 46XX and a few cells which are 45XO. So 2 different cell lines present in the same fluid. When you see a report of mosaicism on an amniotic fluid, if your finding correlates with the ultrasound findings, then most likely it's an accurate report. But if the finding of mosaicism is not explained by any ultrasound findings, then maybe you have to offer fetal cord blood sampling in such a situation to confirm the report. Then there is an entity called maternal cell contamination. What this basically means is that certain higher level tests like microarray, like exome sequencing, like Sanger sequencing, these are certain next generation tests or higher, which are performed on the amniotic fluid. These tests are essentially DNA based tests. So when we order these tests, the first step which the lab needs to run is they need to be able to differentiate that the DNA that they're testing is the fetal DNA and not the mother's DNA. So that is called ruling out maternal cell contamination. To do this, we also send mother's sample in an EDTA, mother's blood sample in an EDTA bulb along with the amniotic fluid sample to compare. So these tests need to require that maternal cell contamination is ruled out. And the chances of a maternal cell contamination is higher if the entry has been through the placenta, because then it could mean that there is some bloody tap. Bloody tap means there's mother's blood which might dissolve with the amniotic fluid. And so contamination may not be able to do, the lab might not be able to rule out contamination with confidence. Or if multiple attempts have been made to enter the cavity, because the more the number of attempts, the more you're passing through maternal tissues, the higher the chance of contamination. Also, operator experience has got a role to play in the amount of samples that you say you cannot rule out contamination. So to avoid all this, a good practice would be to discard the initial 2 centimeters of amniotic fluid that you aspirate. That means you don't send it for testing, you just discard it. Complications of amniocentesis is fetal loss or miscarriage. There are various papers which have given a varying rate from 0.1 to 1%. Rule of thumb, the more experienced the operator, the lower the fetal loss rate. Usually, most people quote a fetal loss rate of somewhere around 0.3 to 0.5%, which means 1 in 300 to 1 in 500 pregnancies. The other complication of amniocentesis that tends to occur is membrane rupture, which can be seen in 1 to 2% of cases, can be seen up to 24 weeks. What needs to be differentiated is a membrane rupture or a leaking following amniocentesis does not behave the same way like a spontaneous membrane rupture. Usually these cases are self-limiting, they resolve, and usually the outcomes are good. So you just manage them conservatively with antibiotics and wait and watch, and they resolve in most cases. Fetal injury is extremely rare in today's day and time when amniocentesis is done under continuous ultrasound guidance. There have been case reports of unguided procedures where the needle has ended up touching the fetus, and then depending upon what part of the fetus was touched, there were various fetal issues which were seen after birth. These cases don't occur so commonly now. And the other set of complications, so basically this procedure is more or less safe for the mother. We can assure the mother that it's not going to be a very life-threatening procedure for her. The chances of sepsis in the mother are extremely rare, and they usually occur if inadvertently, when you are passing the needle through the maternal abdominal wall, you also puncture the maternal small bowel before you enter the uterus. That is one situation where there can be sepsis. Again, since the procedure is done under continuous ultrasound guidance, these complications are also extremely, extremely rare. What factors would increase complication rate? The more number of attempts that you need to aspirate the fluid, the higher the chance of complication. More than 3 attempts, the chances are extremely high. So what the guideline says is, if despite 2 attempts, you fail to get adequate amniotic fluid, it's best to not try the 3rd attempt at the same time, postpone the procedure by a few days and try again. Blood-stained amniotic fluid increases complication. Any presence of fetal anomaly increases complication because fetal anomalies inherently have a chance of fetal loss, and so that kind of reflects in the procedure-related complication risk. Certain other maternal factors are known to be associated with, though not really causal as far as complications are concerned. So mothers with, let's say, a bicornuate uterus, or there's some amount of some area where the chorion is separated from the amnion, or there are multiple fibroids, or it's an obese mother, or the mother who has active vaginal infection. All of these are definitely factors which may have an impact on the risk of complications. Now then, moving on to chorion villus sampling. It's basically nothing but withdrawal of tropoblastic cells from the placenta. These tropoblastic cells from the placenta are also seen as said to have the same genetic composition of the fetal cell. So we test them for when we need to test the fetus. So this test was first started in 1970s in China, where CVS was done transvaginally, where we used to use cannula, which used to be as big as 5 or 6 millimeters transcervically for fetal sex determination. So that is how the test first began. Eventually, it came into clinical practice in the 1980s. And now we have two ways in which we can do the procedure, either a trans-abdominal route or a trans-cervical route. In experienced hand, which means in those amongst those people who have a fair amount of experience with doing even trans-cervical CVS, the procedure rate, or there's no one procedure which is superior to the other. Both have equal results. So it all depends on what one is comfortable with and where is the placental location. So it's timing. So CVS is usually offered after 10 weeks. We usually offer it after 11 weeks so that we can first do an NT scan, rule out fetal or abnormalities. And so usually that's the time when we offer it, usually after the 11-week scan. If you try a CVS before 10 weeks, there have been reports of limb reductions and oromandibular defects. So no CVS before 10 weeks. All practical purposes, no CVS before 11 to 12 weeks. So basically, you need to introduce the needle inside the placenta under ultrasound guidance. How you introduce, whether you introduce trans-abdominal or trans-cervical, those are the two techniques. So in trans-abdominal, since we're using an 18-gauge needle, which is a slightly bigger needle, this procedure tends to be a little bit more painful. Hence, we usually give local anesthesia at the point of entry up to the skin and subacute. We usually use 2% Dignuke. 70 to 20-gauge needle could be used. The commonly used needle that we use is the 18-gauge needle with the pink top. Once the needle is introduced in the placenta, you remove the inner stylet and then you attach a syringe and aspirate, apply suction, and then you move the stylet back and forth up till a total of maximum 10 times. That back and forth movement will help suction some of the placental villi into the syringe. So this is how you pass the needle through the substance of the placenta. So your probe is trans-abdominal, your needle is trans-abdominal, this is the placenta, that is how you go about doing the procedure. In trans-cervical, what we use is either you introduce a biopsy forceps or again a cannula trans-cervical into the placenta. So this procedure in first trimester helps because majority of the times the placenta in the first trimester is very accessible or very close to the cervix. So it's a particularly good way of doing if one is trained in it. It is introduced transvaginally and both techniques are equally effective. Most people who tend to do trans-cervical CVS prefer using a biopsy forceps where you just pass in the forceps, take a chunk of the placenta and come out instead of applying a stylet and a vacuum. So most people prefer using a biopsy forceps. For any kind of testing to be done, the amount of villi that we need are 5 milligrams. We don't usually weigh the villi, that's not what we do, but we have an idea. We do visual inspection of the sample, which over experience tells us whether the amount of sample that you managed is adequate or not. So, CVS has 2.5 to almost 5% of the times it might happen that despite 2 entries also, we might not get adequate sample. That can occur in quite a number of cases. So this is how we do a trans-cervical. So what happens is you keep the bladder partially full. The probe is still kept on the mother's abdomen. So the probe is trans-abdominal. Under ultrasound guidance trans-abdominally, you pass the catheter through the cervix and into the placenta, which is sitting right above the cervix. Failure rate in serious cases is sometimes a little higher than what is seen in an amniocyte. Again, we have to separate. This is how in the picture here, in the petri dish, this is how white fluffy, this is how the chorionic villi look. We need to differentiate from maternal desiccated cells, which typically look red. So we can actually tease out the sample in a petri dish before we send it for testing. Or if you're very sure you have cells, you can just directly send it for testing. The amount of mosaicism that you see in a CVS sample is slightly higher. And once you see mosaicism in a CVS sample, you always confirm it by an amniocentesis. Because there is an entity where only the placenta has 2 cell lines, but the fetus does not have 2 cell lines. So if you see a CVS report which has 2 cell lines, we need to confirm whether the fetus also has those or not. So we confirm a mosaic report in a CVS with an amniocentesis. Complications are similar. The rate of fetal loss is almost same to an amniocentesis. The losses rates are similar between a trans-abdominal and a trans-cervical method. Vaginal bleeding tends to occur more commonly following a CVS procedure, even more so if it is done trans-cervically, where almost 30% of patients might report some or the other form of vaginal bleeding. Most of the times it is not serious. You inform the patient, educate them, and they are usually okay with it. Leakage, amniotic fluid leakage is much, much rarer in CVS than what you see in amniocentesis. And also fetal loss again is very, very less likely. Similarly, maternal complications like chorionitis and sepsis are very, very rare. There are various factors which affect complications, most important being the operator experience. How many entries have you used? If you use more than 2 needle insertions, your complication rate is higher. If the patient is already having very heavy bleeding before you are performing the procedure, that tends to impact. Again, gestation age before 10 weeks, which you don't follow now. Presence of an inherent fetal anomaly impacts the complication rate because that fetus might undergo miscarriage as an account of the anomaly, which then gets reflected as a complication of a procedure. Low PAP-A is also known to have an association with a complication rate because low PAP-A is an indicator for placental dysfunction, like Dr. Pooja just mentioned, and placental dysfunction in itself tends to increase the complication rate after a CVS procedure done. Other factors which are associated with complications, but we don't really know their role, is the same. If there's a small hematoma, not severe bleeding, but small bleeding, retroverted uterus, it just makes access to the placenta that much more difficult, and persistent fetal bradycardia post-procedure. Fetal blood sampling, even though it's not a part of the talk, it's another form of procedure that we can use for diagnosis. In today's time, most cases of fetal blood sampling are used in diagnosis along with therapeutic. So we don't usually resort to fetal blood sampling in this, except for specific instances. It's usually done 18 weeks onwards. A much smaller needle is used, 20 or 22 gauge needle. That means the black or the yellow tip needle. Main 2 indication, if the amniotic fluid is showing mosaicism and the fetal signs, ultrasound signs don't match, then maybe to confirm, we directly check the fetal blood to look at the fetal cell lines. And the more procedure, because in this case, not only will it be diagnostic, but if you confirm anemia on table, we also keep the setup ready for doing an intrauterine transfusion. So the vessel that we target is the umbilical vein. If you target the umbilical artery, the chances of complication are higher. There is fetal bradycardia, formation of fetal hematomas because it's a high pressure vessel. So the vessel that we need to target in the umbilical cord is the umbilical vein. Either we can target it where the cord is attached to the placenta, if the placenta is anterior and the placental insertion is accessible, or if that's not the case, we sometimes target the umbilical vein in the liver. That's the second site where we might do the FBS. So this is a typical picture of, this is the placenta, this is where the cord is inserted. We recognize the umbilical vein, and that is where we put the needle inside the umbilical vein. Presence of fetal hydrops, IUGR, and a smaller gestation weight tends to increase the complications of fetal blood sampling. So more than the procedure, or rather I would say as important as the procedure expertise, what is required is expertise in counseling. In fact, most of us who do the procedures know that we actually end up spending a lot more time counseling the patient about the procedure than the actual procedure itself, which might not take that much time. So what we have to do is we have to detailed review of why the patient is sent. Is it because of some ultrasound finding? What was the screening test done? Was it done adequately? And other maternal investigations. Can do this group of patients are the ones where you can opt for NIPT instead of an invasive procedure, because now, as Dr. Shilpa explained, between a risk of 1 in 100 to 1 in 100 to 1 in 2000, the intermediate risk, we can offer NIPT instead of an amnio or an invasive procedure. So we kind of just because a patient is referred for an invasive procedure doesn't mean that's what you end up doing. If the patient is eligible for a non-invasive procedure, then maybe that's an option which you can consider. The patient has to be explained the procedure details. Exactly what are we going to do? We're not going to give her a complete general anesthesia. We might give her a local anesthesia only. So she's going to be conscious. She does not need to come fasting. In fact, it's ideal that she eats something and comes. And how long is the procedure going to take? She's only going to be there for half an hour, maybe after the procedure. It does not require admission. It's a daycare procedure. She's going to go home after the procedure. And then a brief list of complications, like I just informed. Then the timing, like depending upon why she's sent and what weeks of gestation, whether we offer a CVS or an amniocentesis. Sometimes that decision is also dependent on the indication as to why she's sent. Also, what tests are we going to perform on the procedure? Are we going to perform a simple karyotype? Are we going to offer a microarray? What is the time in which the test is going to come? What all can the test detect? Some patients feel that if we do a microarray or if we do a karyotype, because the risk of trisomy 21 was high, they think that rules out all causes of mental retardation. So the patients need to be told that we are only going to be able to rule out a chromosomal abnormality if we send a karyotype. That does not mean that all sorts of genetic issues in the fetus have been ruled out. So it does not mean that the fetus is going to be normal. It only means that the fetus chromosomes are normal. So yes, it answers the question for Down syndrome only. It does not necessarily mean that the fetus is in the end going to be completely normal. So that difference needs to be explained to the patient. Otherwise, later on, it can lead to issues. So the limitations of the test and failure rates. Also the cost. And if she's Rh negative, then anti-D also needs to be given and that needs to be explained. So what are the common indications for which we do invasive procedure in today's day and time? Even today, the biggest chunk of group is aneuploidy, where you're suspecting a chromosomal abnormality. That could be as a result of a screen-positive dual marker or a quadruple marker or an NIPT. All these are screening tests. So if they come positive, we have to rule out or we have to confirm the abnormality before we offer termination. And certain ultrasound findings like an increased NT or structural abnormalities in an ultrasound or markers for Down syndrome that we see on an anomaly scan. If there is a previous history, like if there's a previous history of a fetus with, or they have a previous child with Down syndrome, and that Down syndrome is not a pure trisomy 21, but a translocation. So what it basically means that parents, one of the two parents have a chromosomal rearrangement in them, so that when they reproduce, the chances of the subsequent fetus also having Down syndrome is higher. So that is another indication that we might want to offer an invasive testing. Then apart from aneuploidies, which are disorders of the chromosomes, there are disorders of genes at a much, much smaller level, for which we might offer invasive procedures. Usually in this group of people, we have a previous sibling or a relative who suffered from a genetic disorder, whose diagnosis is known. The exact mutation why that disorder has happened is known. So then we test the pregnancy for that specific mutation in this pregnancy. So that's another important subset of people in which we offer invasive procedures. Third subset is fetal infections. Either the mother gives a very positive history and diagnosed with one of the torch infections, which are transmissible in pregnancy, or we see certain ultrasound findings, like we see echogenic bowel, or we see multiple calcifications along with oligohydramnios, or we see brain calcifications. So whatever the reason, fetal infections, if we suspect, then one of the ways to rule it out is by invasive testing. And last is maternal request. There are some parents who are simply very anxious. They've done all their Google searching. It is your duty to explain that if they do opt for a procedure, they're doing it where the risk of a loss because of procedure is probably higher than the background risk that the baby might have an abnormality. If they understand all that, and if after that they still wish to go for an invasive procedure, then we may document it and still offer it to them. What is the checklist that we follow when we offer these procedures? Most important is the mother's blood group. If the mother is Rh negative, we check the husband's blood group. If the husband is Rh positive, we ask for a baseline indirect Coombs test to show that it is not a sensitized pregnancy so far. If that baseline test shows that the mother is not immune sensitized, then after the procedure, we need to give an anti-D injection within 72 hours of doing the procedure so that the procedure does not cause sensitization. We don't want to increase her trouble because of a procedure that we've done. What medications is she on? Most specifically, is the mother on low molecular weight heparin or aspirin? Both these medicines are blood thinners. So while they're not contraindications for doing the procedure, but it is good to know that they are on these medicines so they can be stopped in a timely fashion before we do the procedure. Ideally, an HIV, HbA1c or an HCV report is not really needed as part of the checklist. However, if you already know a mother, if she's, let's say, HIV positive, and if she's already on antiretroviral therapy, then the risk of a transplacental transmission is extremely low. Similarly, if the mother is HBV positive or HBsAg positive, as long as a viral load is low, as long as our HBe antigen is negative, the risk of placental transmission to the fetus is low and the procedure can be offered. Usually, routine antibiotic prophylaxis is not recommended as per the guidelines. However, depending on the scenario, we may offer it in certain situations, as long as the procedure is done under clean aseptic precautions. And the procedure should be accompanied by a detailed procedure report giving details of whatever was done. So the aseptic precautions that include is we need gloves, sterile gloves, gauze pads, the equipment used, the instrument used should be sterile. Maternal mother's abdomen is usually cleaned with either chlorhexidine or betadine, iodine as an antiseptic solution. The ultrasound probe, which we put under maternal abdomen, it is ideal that you cover it with a sterile bag, or if you don't do that, then you just disinfect the probe. And then sterile containers, which are usually provided by the lab for carrying the sample to the lab. In CVS, local anesthesia, 2% xylocaine or lignocaine can be used. So this is what a trolley would typically look like. These are the tubes, the CVS tubes. This is the syringe to aspirate. This is a petri dish, which some people use. Sterile gloves. These are the instruments used to hold the cervix. This is for a transcervical procedure. And this is what we mean. This is the probe. We cover the probe with a sterile glove so that the surface of the probe is not infected. And so that's as much of disinfection as we can achieve. Procedure report should indicate, give the reason why the procedure has been done, details about the procedure, what route was used, was the placenta avoided or not, what needle was used, how much sample was aspirated if it's an amniocentesis, how many entries did we make, if you've done amniocentesis, any relevant findings, like if the amniotic fluid is red colored or old blood stain, like like bile colored, then that needs to be mentioned. If specific findings on screening ultrasound was positive, that needs to be mentioned. What tests did you send for? What instructions do the patient needs to follow after the procedure? And when does she follow up with you? All of this should be mentioned in the procedure report. So post-procedure, we might ask the patient mild restriction of activities for a day, especially only because it tends to be painful, not otherwise. Routine antibiotic and prophylactic is usually not recommended. It might be given in certain situations depending on the situation. Paracetamol for pain, specifically after CVS, the patient complains, they may take paracetamol till pain is there, usually a day or two, and anti-D without fail in the deltoid, preferably within 24 hours, maximum up to 72 hours. No need to usually stop. There's no data available with regarding stopping both heparin and aspirin, but knowing that the patient is on them, at least stopping low molecular weight heparin 24 hours before the procedure. So why that's important is, if you decide to send a patient to me for amniocentesis tomorrow, and if you've seen and from your end, if your checklist is complete, the procedure gets done timely fashion. So if you know you're sending a patient for amnio, maybe it's a good idea that you stop heparin, you stop aspirin. See to it that her patient blood group report is available. If she's Rh negative, see to it that at least you've sent for an ICD, so that by the time she comes to the procedure, that report is available, and make anti-D available. So knowing the checklist also helps the referring doctor, so that certain things can be done at their end, so that things get done in a timely fashion. Just briefly, in twin pregnancy, as Dr. Pooja so well explained, you have here also it matters whether it's a dichorionic twin or a monochorionic twin. Dichorionic twins, we assume each baby is genetically dissimilar. So we usually offer sampling for both babies. In an amniocentesis, what we simply do is we puncture each sac separately. There are studies which say you put a dye in one sac to know that you're not punching the same sac again. But in expert hands, that rarely happens. Under ultrasound guidance, we know which sac is supposed to be entering. So we usually don't enter the same sac twice. If the patient is only opted for testing the sac or the fetus which is having signs, then confirm and reconfirm the ultrasound finding for which we are testing, so that that sac only gets tested. There's a single puncture technique which has also been described, but which usually most people don't follow. Similarly, in a dichorionic twin, if a CVS is planned, we usually tend to plan both entries as far away from each other as possible. Don't stick to the cord insertion area, so that we don't go very close to the intertwin membrane. In CVS, there is almost a 3 to 4% sampling error when you try to sample two separate placentas. Cross-contamination is known to occur in 1% of the cases. If one placenta is frontal and the other is low-lying, ideally, we could access the low-lying placenta via transcervical route and the fundal placenta via transabdominal route to decrease these issues. In a monochorionic twin, you only sample one sac because monochorionic means the fetus are also genetically identical. So if one fetus is showing an abnormality, genetic abnormality, it will be present in the other fetus. So just sample one sac. If for some reason the two fetus are discordant for a particular abnormality, in those rare situations, we might offer sampling for both fetuses. If this occurs at the time of CVS, that on CVS, there is a fetal discordance, which is not explained by monochorionicity, and we need to test both the fetus, it's ideal to just defer the procedure and do an amniocentesis, because testing two ends of a single placenta is going to lead to more errors. To which procedure would you prefer? It's basically decided by A, the timing, and B, the indication, because both procedures have similar fetal loss. CVS might be slightly more painful, but otherwise the outcomes are perfectly comparable to amnio. In fact, if we have a couple where the previous baby has a genetic disorder and we know while they are pregnant that this pregnancy needs to get tested, CVS is the ideal procedure to offer because it has a very good DNA yield. Amniocentesis is relatively less painful. It can be offered in certain cases where in the first trimester, like for somebody like me, I don't do transcervical CVS. So even though the first trimester we need to do testing, but if the placenta is low lying, not accessible through transabdominal route, I then wait till 15 weeks and offer an amnio, which is a simpler procedure instead of doing a difficult transabdominal CVS. Fetal infection is one indication where we always offer an amniocentesis because those viruses which we test for are shedding a fetal urine. So testing the amniotic fluid becomes important. Plus, we need to give at least 5 to 6 weeks for the transmission from the mother to go into the fetus and the virus to be shed. So to rule out infections, fetal amniocentesis is the procedure of choice. Again, if you see mosaic patterns on a CVS, you offer an amniocentesis to confirm. Let's say you done a CVS and in that report they said that they could not rule out maternal cell contamination, which means they do not give you a report. Then you need to do a repeat procedure, and in that situation, you might end up doing amniocentesis. So to summarize, amniocentesis, CVS, and fetal sampling are all diagnostic invasive procedures. What procedure to use is decided by the timing, indication, and the expertise. They almost, CVS and amnio both have similar loss rates in experience hand. As important as doing the procedure, or I would say probably even more important, is to follow the checklist, to counsel, and to report your findings. Thank you.
Thank you, Dr. Shetal, for describing in detail the important invasive procedures of amniocentesis and chorionic villus sampling. Ma'am, can we once again go back to the slide on the slide of chorionic villus sampling with amniocentesis with respect to the timing? Yes, ma'am. Can we?
So I would just like to emphasize that for some reason there's a general idea that CVS is a procedure with a higher loss rate. Like there are obstetricians or referring doctors who feel that even though we know at 12 weeks that the fetus is going to require a procedure, they prefer amniocentesis because somehow it's an old concept where they think amniocentesis is safer and not CVS. So, which is just to reiterate that CVS is as safe as an amniocentesis. It's only a question of technicality if the placenta is accessible and if we know that, let's say, as described previously, the NT is high, there are first trimester abnormalities, or we know that, let's say, the couple has a previous child with some single gene disorder which needs to be tested in this pregnancy. So when we know at 11 to 12 weeks that this fetus is going to require a procedure, let's say the couples have carriers for thalassemia trait. So when we know that testing needs to be done, then there is absolutely no reason to defer the procedure to a second trimester. Early testing gives early results and easier for the patient. Let's say we ruled out certain abnormalities, that much easier for the patient. Let's say the report comes abnormal. Again, first trimester termination can be done. So patients also find it better because not, they can disclose whether or not they're pregnant or they're good news, bad news, whatever accordingly. So there is no reason to defer a CVS to second trimester except for specific indications like, let's say, fetal infection or technically difficult or mosaicism as seen on the CVS. So that's the one point I wanted to get across, that both procedures are equally safe and no reason to prefer one over the other specifically.
Yes, ma'am. Thank you so much, ma'am. I would like to inform our audience that Dr. Chander Lulla's talk on scope of fetal interventions in the first trimester will have to be cancelled. Actually, sir is caught up in an emergency surgery. So this will be scheduled later and you'll be informed about the same. So we've completed our discussion part. If we have any questions, we can take questions for our respective speakers. I don't think we have any questions. So I would like to thank our speakers, Dr. Shilpa, Dr. Rajani, Dr. Pooja Vazirani, Dr. Shetal Mehta for the amazing discussion. And also on behalf of Dr. Rasiksha and our team, we'd also like to thank our audience for the patient listening. Thank you so much.
Thank you, everybody. Thank you.
Thank you.
Thank you, everyone.
Thank you.